TIVA app, which you can use it to practice passive TIVA. That means use a normal infusion pump and use this TCI app to give precision anesthesia. What a wonderful introduction you have had. We can't have a better preparation for the master to come and give his master stroke and take us to the next level. Dr. Tushar, welcome. We want to hear from you. I know you will take us from normal routine to excited state. Look forward to hear from you.
Thank you, Dr. Subra. On the outset, good evening to all my webinar attendees, including my resident, my esteemed future president of ISA, my good friend, my IOTA president, Dr. Subramaniam Mahankali. And today I am very much thankful to my very good friend, academic friend, Dr. Meenakshi Sundaram, for giving me opportunity, such an august gathering in a webinar. So today's my topic is just generally offbeat topic because I am an AI man. So I will talk about the future of the anesthesia, what the smart anesthesia will look. So my topic name is Smart Anesthesia TCI TIVA with AI integrations. There are some of the lectures on AI is very popular in all over India. So I have highlighted two quotes for there where precision meets the intelligence in anesthesia and infusing our intelligence into the smart anesthesia powered by artificial intelligence. So first of all, I will define some of the definitions. People know the definition, but I want to highlight again what is smart. Why we use smart everywhere? Because smart is a system, device, or processes that are intelligent, adaptive, and efficient, often using technology, automation, and data-driven insight to optimize performance. Nowadays, you are using smartphone, smart home, smart car, smart monitoring. So specific, measurable, attainable, and relevant and time-based makes goal your specific, define measurable assets, confirm your goals are attainable, verify your goals are relevant, and set up time based on your plan. Suppose I don't have any idea about how to use ultrasonography machines to block my nerves. Not to worry. My AI will take over that. I will put my probe on the sonography machines of my patient's body, and the AI machines will tell that this is the nerve here is lying and you just block it. So that is the way our smart anesthesia is coming in the picture. I'm in this field since last 10 years and all the parts of the world where I am taking lecture, my artificial intelligence is going too much in deep. So what is smart anesthesia? The use of modern technology means TCI machines, then all the our depth anesthesia monitor and AI to make both gas anesthesia as well as TIVA more precise, safe and personalized while keeping the anesthesiologist in a full control. The basic definition of TIVA, people are having a myths about this TIVA. That's why I go to some basic definition of TIVA. Dr. Sipriya and other PG students have explained very nicely about TIVA. But again, I want to tell total intravenous anesthesia is a technique of general anesthesia which uses combination of the drug given exclusively by the intravenous route without the use of inhalation agent, even gas anesthesia, including nitrous oxide. But here oxygen and compressed air or helium are exception. So TIVA is used in induction and maintenance of anesthesia. I'm also highlighting that part. Whether you intubate or not, whether you give supraglottic airway insertion or not, TIVA is used in all the way. So what is TCI? Dr. Sripriya, my previous speaker, has explained very nicely that target control infusion is a simple definition. TCI is an infusion controlled to achieve preset drug concentration in the plasma or the effect side. You do not have to worry about the doses and pharmacology and this and that and that. Now your target control infusion pump will take over. The basic difference between the simple infusion pump and target control infusion pump is that there is a computer in the target control infusion TCI pump. This will take over then she has explained very nicely how it works. So come to the what is smart anesthesia TCI TIVA, a closed loop or clinician guided system that combines TCI, that is target control infusion algorithm. All the algorithm she has explained very well. TIVA drugs, all the regimens and AI-driven feedback. We are using all the depth anesthesia monitor, all the opioid like no, annual monitors, BIS monitor or hemodynamic variables to individualize the drug delivery in real time with the right patient in a right way by the anesthesiologist. That is why my downline punchline is that today's anesthesia is not going to kill any patients in future. If you want to kill your patient under anesthesia, even a particular dose, then also patient is not going to die. That is the way anesthesia is coming in the way. Now, since last 180 years, when our anesthesia introduced, we have invented 70 drugs in anesthesia and that we were using it. Out of this, these 20 drugs are not in use. This is just for our resident to highlight how these drugs are used. In TIVA, we are using 50 drugs. That is why I am the main person to using since last 25 TIVA and TCI in my practice or private practice since last 33 years I am practicing. And in TCI, we are having a 7 drugs of advantages to use that part. You know that in 1990 when the sevoflurane was introduced in the market, after that there is no inhalation agent. But every year you see, every year TIVA drugs are invented. Nowadays next generation AI drugs are like ciprofol, which was invented last year. And coming way, Remimazolam was invented in Japan by 2 years before. They are also in pipeline. And another pump like TCI pump are in the market, will be in the market within 5 years to have these drugs on this TCI pump. Now people are telling two things. They tell that without gas anesthesia, our anesthesia is not complete. I bet that TCI TIVA completes the anesthesia cycle because it gives hypnosis, sympatholysis, amnesia, hemodynamic stability, immobility and neuromuscular blockade. All the drugs facility, we have ample choice of using these drugs in our armamentarium, whether we are using muscle relaxant or this. This is called TCI TIVA completes. So TCI TIVA is not a bogus anesthesia. It is not a incomplete anesthesia. It gives complete anesthesia circle. There are some advantages, except for this is just for the highlight of the advantages. Except for the slight prick in the arm, the patient is unaware of the having an anesthetist, because in gas anesthesia we have to put the mask, we have to put on that, this and that. People may not like it. No mask over the face, no sudden concentration of gas or vapor, no risk of malignant hyperthermia. If you read your on WhatsApp group, in last 6 months, there are 5 cases occurred in all over India because of the malignant hyperthermia, and in every city branches are keeping their dentrolene in their armamentarium. Even in Vadodara we have kept our this malignant hyperthermia, and out of 5 patients, 3 patients died. So because of that, we are not recommended to use. No doubt I am not against any gas anesthesia, but nowadays the coming era is of the TCI TIVA. So the no risk of malignant hyperthermia, very low incidence of post-operative delirium, less chances of emergence phenomena, better preservation of the cerebral autoregulations. It gives less PONV. In my practice, since last so many years I am practicing as a TIVA, then TCI, then advanced TCI. I have never seen any patient having a PO, post-operative nausea vomiting, because there are so many drugs are available like Dexona, then ondansetron, then Sultaren, everything. Less operating room solution. There is no need of scavenging system. So now come to the why we need for the smart anesthesia. Here, people have to understand that suppose today I done one case, I will go practically. I have done one tonsillectomy of one 10 years old child. The same type of the patient with the same age, same criteria that comes in the second day for the tonsillectomy. But I will change my anesthesia plan. So every patient is different with the age, weight, renal, hepatic function, comorbidity, drug response to all very widely. So procedure today are more complex even with the minimal invasive technique requiring careful anesthetic titration. So there is a variability in the patient's response. Today the same patient for propofol response may not respond. They respond very deep anesthesia. Procedure complexity. Sometimes surgeon takes more time to complete the surgery. Demand for better outcome. Our surgeon demands nowadays daycare surgery. So that is why we need for the smart anesthesia now. TCI TIVA again going in the next few new generation is a smart anesthesia. So there are 6 smart anesthesia component. First, Dr. Sripriya has very nicely explained the TCI TIVA algorithm. So precise drug delivery methods by TCI pump. Precision dosing. Dr. Subramaniam has told us that there are some specific drug dosings are given to every patient. So right dose for the right patient. Suppose today I was given when I was given anesthesia for spine surgery, my dose was only 1 milligram per kilogram for propofol for as my anesthetist told. But other patient may require 2 milligram. So individual drug delivery, tailor medication strategy, patient-centric monitoring, feedback-driven individualization. All these depth anesthesia monitors are working on that part. AI-driven feedback. This is a new words are coming that AI is taking in part of this TCI TIVA regimen and adaptive infusion, drug delivery guided by the patient state where the depth anesthesia patient becomes light, patient becomes deep, then patient's hypotension occurs. According to that level, AI will decide by the smart TCI TIVA that how much drugs to be induced, what level should be kept in that state. So my objective of smart anesthesia is principle of TCI and TIVA, clinical applications, workflow integrations, AI enhancement, and future trend and ethics. So on these principles, I am going to tell my next slides in detail. Why there is a changing landscape of the anesthesia? Because there is a shift towards more personalized anesthesia delivery. Every day we cannot give the monotonous type of the anesthesia. Today we are giving propofol, remifentanil. Today we are giving to one patient. Every day when I am going for cholecystectomy, then all these basic principles are there. No, there is no need like that. I don't know about these patients, but if I feed everything in my pump, then they will take over. So need for enhanced precision and control over drug administration. Incorporation of the advanced technology in practice. We have a lot of AI gadgets, like we have a chatbots, we have a ready reckoner TCI pumps and this ITIVA apps. There are so many other apps are available to grow AI role in perioperative medicine. This is also one of the best idea to have this changing landscape. We'll come to, my topic will be divided in 2 parts, TCI and CLADS. CLADS means closed loop anesthesia. TCI, C has explained very nicely. TCI is a target control infusion, computer driven pumps that adjust the infusion rate and maintains the target plasma or effect site concentration. How it works? There are core components are user interface. So it looks like a simple infusion pump. The resident, those who are using simple infusion, they can switch over to and they can learn easily this our TCI pump, but they have to read something, they have to attend this type of the webinar, they have to attend the workshops, and from IOTA, our association, we are every year organizing so many workshops. So user interface, PKPD softwares are incorporated in this TCI pump, and there is an infusion pump control, which are the models are available. Mars and Snyder. There are 4 generation models. First generation, second generation, third generation, and fourth generation is AI model. So Mars and Snyder are the first generation models. Kataria and Perfuser for the pediatric. These are the Minto, Bergman, Maitre, GAPS are the for the opioids. They are different for the this remifentanil, then fentanyl, then other sufentanil, alfentanil. Domino, Eliveld. Eliveld is a new third generation pump available, that is, and Dick and Honeywood. Just these last two pumps are invented for the dexmedetomidine, and it is in the pipeline. They are having this, all softwares have in a general purpose model. What are the advantage of the TCI? Predictable anesthesia depth. Predictable. You do not worry about this awareness in anesthesia. This will create a havoc in past. I see lot of cases in private practice that our surgeon tells that my patient should show tongue, he should show eyes, and he should talk on table whether patient becomes aware or not. but that was the very shrewd anesthesia. I tell that days were gone. I started my practice in ether anesthesia and switch over to lastly sevoflurane, and then I started from Potvin to remifentanil. So predictable anesthesia depth, fast recovery. Now today's everybody wants fast recovery, less PONV. There are two main complications in GAR: post-operative pain and patient having post-operative nausea, vomiting. If these two complications you take over in your practice, then you are mastering your anesthesia practice. And these two things you must avoid in your patients when there is a recovery in the post-operative period. Optimize drug use and cost efficiency. TCI uses PKPD models to maintain a target plasma or effect size. When it came in 1990 with the deprifusor, as Dr. Subramaniam told that propofol is our king or prince. After propofol, everything was possible. Propofol was the switch on switch of anesthesia. Like nowadays, I put a remimizolam, not remifentanil. Remimizolam is this switch on switch of anesthesia. It's a new generation drug. In 2026 or 27, remimizolam will take over the world, and after that in 2030 you will believe me and remember that in 2030 China has invented ciprofol and it will take over the propofol, and every part of the world ciprofol will be in the use. It is better than even propofol. Dr. John Blair Glyer, Dr. Bain is from England, is the father of this TCI. Again, I am just highlighting another way of remembrance that how it works. 3-compartment pharmacological model, and bolus drug is given to central compartment. It distributes in the V1, C1, C2, C3. It eliminates in through the kidney. It goes in the effective side. Cypriya has nicely summarized everything with the graphs and everything. I do not go to in detail on this part of this slide. But this diagram shows the 3 compartments. The central compartment represents plasma lever when infusion and elimination occur. Peripheral compartment includes C2, muscle, highly perfused, fast equilibrium, and C3, fat, less perfused, and slow equilibrium. Drugs are distributed between compartment via rate constant, distributed and redistributed. Elimination occurs from the central compartment, and the effect side is linked to the C1 through the Ke0, reflecting clinical drug actions. This is the way the circuit is going on in the TCI pump. Now, these are the models are available in the market. Mars model. In bracket, I have written the which generation model is there. Just to know you people that how many types of the models are available for the specific drug. Mars was first invented in this after deprifusor pump, that is propofol. Snyder is second generation model. Pedfusor and Kataria is for the pediatrics. This is used for the more than 3 kg. Minto for the remifentanil. Nowadays we are using for remifentanil in India. One of the company Themis came with the remifentanil, and every part of the, now you know the beauty part is that now out of 28 states, only 8 states are remaining to have a remifentanil. All other states are having a facility of remifentanil use. In our city also we are getting remifentanil. Bergman, fentanyl we are not using. Then another narcotics, this TCI pumps are, we are not using it. Aliwell model is a 3rd generation model, and they have recently introduced in last 2 years for propofol and remifentanil. Domino for ketamine, Dick and Hennywood for the dexmedetomidine, Greenwald for midazolam, and general purpose model. You won't believe that when I started my practice TCI TIVA in 20, means before this corona, at that time all over India, Dr. Subramaniam will be agree that all over India there will be hardly 5 pump will be available. That is also with this Bangalore people. But today I should take it proud that there are more than 5,000 installation of the TCI pumps all over India by all the company. All pumps are available in all over India. So these are, which are these pumps? These are the TCI pumps: Arcomed, BD Elaris, HP Med Captain, B Brown. These are the few pumps are available, and the average price of these pumps starts from 1.5 lakh to 2.5 lakhs. Now my imagination is 4th generation TCI TIVA pump. This is my smart anesthesia. This is my smart TCI TIVA. AI driven, adaptive, closed loop, and pharmacogenomics driven. moving from simple PK models to truly smart autonomous anesthesia machine. You do not have to worry about any pharmacokinetic or pharmacodynamic of any drug. Just go and feed the data on this pump and pump will take over. Like we are running a cruise control over the car. Our car, when we put over the speed limit, then it will run automatically. Even if somebody comes in front of the car, then car automatically stops like that. Now how it looks, fourth generation, this is my dream. Integration of AI and big data predicts patient's response using real-time analytics, machine learning and pharmacokinesis. In this machine, more than billions of the data will be fed, like chatbots, our chat GPT, which is fed by the so many articles, so many researches and like that. So this machine will be fed like that. So it's a great computer. This is artificial computer. So closed loop control. Infusion pump adjusts automatically based on the feedback. And for this, we are using bispectral index, entropy. These are all depth anesthesia monitor, null receptors monitor, that is a opioid receptor monitor, hemodynamics, multi-modal inputs, combined EEG, nociception monitor, hemodynamics, and even variable biosensor. And according to that feedback, this pump will act all these. And I will come back to closed loop anesthesia. Adaptive and predictive, learns patient-specific PK/PD model. I told you, just feed the data and they will remember that for this patient, next time when this patient will be given anesthesia, then this same patient will be having these parameters. Towards fully autonomous anesthesia, anesthesiologist supervise while AI manages titration dynamically. It is my dream. This pump is not in the picture now, not is in the production, but remember in 2030 this type of the pump will come. Some TIVA TCI sets are available. These are the TIVA sets. There are two lines are there, drugs two. One is for fentanyl, one is for ramifentanil, one is for propofol. And the infusion line is different and directly it will be connected to the IV line. This type of the IV sets are also available. Now come to second part is closed loop anesthesia delivery system or automated total intravenous anesthesia. This is the ultimate of my topic. This is the smart anesthesia TCI TIVA. Closed loop system is the ideal means of automated. Here what inputs, whatever we are injecting in the body is a input and whatever the feedback, whatever the vital signs are coming from the body is an output through the monitors. So drugs are input is a drug. We are injecting drug like propofol opioids and according to that response the monitor shows how it works. When these are all infusion pumps, so drugs are delivered in the body, then the body reacts like for what type of the monitoring is that, null monitor or entropy, what type of the depth anesthesia is there of patients, and accordingly vital signs will be adjusted and computer will decide that okay, what drugs to be induced. Nowadays in my fourth generation pumps, the pump will decide that okay, which type of the drugs, whether I want to put dexmedetomidine or I want to put a ketamine or I want to put a remifentanil more or I want to put a propofol more. So according to that, closed loop anesthesia will circle out everything. Patient himself it will maintain. See, you remember the ether anesthesia. In ether, patient will never die. Our surgical anesthesia says, colleagues are saying that okay, ether will maintain itself the deep and light anesthesia. This for the PG resident to remember that part. This is the way diagram is shows. So clinical benefits of the closed loop system is dose fine tuning, adjust based on the surgical stimulus, whether such a surgeon is cutting some vital signs or a vital monitors or vital structures or suppose skin is cutting then patient anesthesia is less, then it injects more. Safety limits, it stops the drug for the dangerous drops. I told the incidence of the cruise control car, if it goes more than 80, if you have a limit of 80, then if goes 80, then the alarm buzzers. The same way, if the BP or heart rate drops down or there is a hypoxia or there is a bronchospasm, everything will be told by the AI and AI will speak over that, like our Alexa and Siri system. This is the way the pumps are coming here. They will speak out that please listen that hypotension is there, so anesthetist will intervene and he will inject something. It gives the free hands, and anesthetist can focus on other tasks, real-time monitoring, alerts for the abnormal patient reaction, and auto delivery. So what is the difference between manual anesthesia and automated anesthesia? There is a high workload. Every day I am doing 6 to 7 cases, but I am tired in the evening. But nowadays, after automated anesthesia, after my TCI pump, I do every day 10 cases till I am not tired. So this is the beauty of TCI TIVA, and even after TCI TIVA with AI, I don't know how much work efficiency I will get. This is the picture showing 3 different pictures that how closed loop anesthesia models are there. See, this is a computer, this is the infusion pump, and this is the monitor, depth anesthesia monitor. So this creates a circle. The one thing I want to tell you, our Dr. G.D. Puri from Chandigarh, who was a retired professor of this PGI Chandigarh, he has invented this CLADS, closed loop anesthesia system. And recently there was a World SIVA conference in Chandigarh. Unfortunately, I have not attended. I think Dr. Subramaniam has attended. But now CLADS is the ultimate things in the anesthesia. All in one TCI TIVA, CLADS and TCI both together like a Swiss jackknife. Both are working together. Both the pumps will act like together and they will give the more accurate anesthesia program. Why combine TCI TIVA with AI? Because traditional TCI, whatever the Sripriya told, it was a traditional TCI. It was a predetermined infusion algorithm based on pharmacokinetics models, but does not adapt to change the patient's conditions. Suppose patient condition deteriorated, patient becomes slight, so TCI TIVA with AI, here artificial intelligence uses his intelligence to optimize the delivery. You do not have to worry that I will give some bolus dose of remifentanil, when to stop my remifentanil. Even remifentanil automatically stops. It will predict the time that surgeon has started the suturing the peritoneum, and it will reduce the dose. That is the way it will work. So advantages are balancing precision and efficiency in TCI TIVA with here, precise depth control. See, at the 60 of depth of anesthesia, means BIS reading, some patients are deep, and at 60 some patients are light. You do not have to decide. That will be decided by AI only. So there is a precise depth control, reduced drug doses. In this matter, I want to tell, when I was using propofol as a bolus dose, when total IV anesthesia, before invention of my TCI pump, at that time I used to give for short anesthesia 3 to 4 milligram per kilogram of body weight this propofol. Nowadays I have reduced to 1 to 1.5 milligrams. So there was a lot of wastage of the drug, predictable pharmacokinetics, and improved efficiency. So TCI TIVA will balance this solution. Routinely on AI having some advantages of anesthesia. See, I told you that in these 4th generation machines, lot of billions of the data was incorporated. So machine learning models predict patients' responses. Every part of the world, whatever the GA cases are done, they will be put in some computer level data, and they will create a very good analysis. So continuous analysis of EEG, entropy, and hemodynamics, early warning of instability or inadequate death. And these are the smart monitors we are using nowadays. These are all available in the market, but they are all costly one. Just now, if you go to this bispectral index monitor, entropy, process EEG machine, null monitor, all these around 3 lakhs rupees. And all these are now, every part of the world they are using these monitors. But everybody has in our private practice, we don't have that facility to use every theaters. So I use my own machines, and I carry with my machines in some theaters. So smart TIVA, by smart monitors, how they converge? By adaptive algorithm, BIS integration, entropy analysis, null integration, and patient response. So to complete this TIVA TCI by AI, these monitors are needed. We need a AI pump. So how algorithm adjusts the target based on real-time data, BIS integration enhances system monitoring and control, entropy analysis optimize system performance and efficiency, Null integration improves the system and accuracy. After the null monitor came, we are very fortunate to have a opioid monitoring and patient's response curve. The response of the curve will be also a learning part and adaptations. So overall advantage of smart TIVA is only major three part: faster, quick adjustment and emergence, safe, low risk of awareness or overdose. I hardly see awareness in my anesthesia after since last 10 years when I started my TIVA practice and after TCI. Precise, reduced variability and among patients. So ultimately it is patient friendly, surgeon friendly, anesthesiologist friendly, economically friendly, environmentally friendly and a productivity friendly. I don't think that you should omit your gas anesthesia, but at least you start your TCI and TIVA in your practice. But there are some smart TCI TIVA challenges and limitation. Financial investment needed. For closed loop anesthesia, minimum 25 lakhs rupees of the investment is to be needed. Every depth anesthesia monitor is 3 lakhs rupees. Every smart pump is, this TCI TIVA pump is available at around 2 lakhs rupees, and other monitoring systems also are very costly. This even remifentanil is also 1800 rupees in the market, but we have to shift our change. Compliance delay the adoptions, clinical validation. So high cost and training and sometimes regulatory approval hurdles. See, I want to tell that I have to convince my senior people, my owner of the hospital to have a TCI pump for 3 years continuously. Then I got the TCI pump. This is the way we get as an anesthetist the problems. Sub safety consideration in smart TCI TIVA. It is not like that when the TCI TIVA comes with the AI, smart anesthesia, then manually we should not be present. AI will not replace us. Manual override always to be available. The anesthesiologist must retain full control to intervene immediate. Our cognitive part will be less. They will take over. But our tactile part, whatever the hands, our hands are working to inject a syringe, to prepare a syringe, to inject in the vein, or whatever the way we have to act in an emergency, that we will decide. AI is an assistant, not a replacement. AI support decision making and precision, but does not replace clinical judgment or expertise. So continuous monitoring for artifacts. Nowadays, all these were alarms and some faulty reading. If you don't know how to drive a car, if you don't know how to operate a smartphone, if you don't know how to do any smart things, then you should learn first, then you do. Otherwise, just go and somebody is doing this job, some doctor, some anesthetist has previously started this type of the machines, then you should take. No, you buy this TCI pump, but you, for that you attend one workshop, you read some journals, you see, you should have some knowledge, this type of a webinar, then you practice it. Some future directions. You believe that this TCI TIVA AI, it will be a next level of the anesthesia in smart TIVA. This is a genome anesthesia. This is genetic pharmacology integration. Suppose as a Dr. Tushar Chokshi, 60 years male, is given a spinal anesthesia or something like any general anesthesia for laparoscopic surgery, then any anesthetist should not have. My genome data is with them, then they will feed over the smart pump, and that pump will take over everything. Which drugs to be introduced, what time will be there for the surgical stress, what time will be taken for the induction, what type of the PKPD, individual PKPD will be there for the individual drug for this. So genetic pharmacology, tailoring drug dosing based on individual genetic data. Wearable device integration. Even this continuous glucose monitor, heart rate sensor, oxygen trackers, everybody will be integrated. My ambitions to see these pumps will have some minor monitors which will show some glucose monitoring, then pulse oximetry, everything. Autonomous anesthesia system. I will show at the end of the slide set how I have developed one of the AI enabled this anesthesia workstation of 2030. So developing AI system for precise anesthesia. It is not like that only pump will work for the smart anesthesia. Even we have anesthesia machines also for the AI driven. Now I'll describe the two cases of how smart TCI TIVA with AI be there. One 65-year-old male, 80 kg, hypertensive, diabetic on treatment, scheduled for the laparoscopic cholecystectomy. He is a grade 1 patient. So in pre-operative phase, I have fed all the data in AI. Now AI selects the Snyder model and Minto for the remifentanil, Snyder for propofol. Induction dose already AI pump has selected, that is 4 microgram per ml, and remifentanil 3 nanogram per ml. And AI adjusts infusion with the Bayes and entropy feedback. So it will adjust like 3.8, 4.2 like that, 2.8, 4.2. Maintenance with surgical stress. When surgeon has started introducing trocar, so my null receptors has detected that null rises more than 30. So I have to put more opioid, means I do not have to put, but AI increase the opioid dose automatically, and it stables the SC for 45 to 50. In intraoperative adaptation, hypotension detected by AI. So MAP was 60 ml. AI pauses propofol and it alerts, it gives the alarm to the anesthesiologist by voice activating. It give vasopressors because infusion resumes at lower rate. In emergence at the post-operative, AI predicts the surgery end and it gradually tapers the infusion. So in recovery, smooth wake up, no agitation, minimal PONV, lower opioid use, and surgeon satisfied with the condition. This is the most safest anesthesia which by smart anesthesia I presume. This case highlights two things: precise drug titration with the predictive algorithm, real-time closed-loop adjustment based on monitoring, fewer complication, no smooth recovery, and still requiring the anesthesiologist oversight. That is why I told it will not replace anesthetists. Our presence should be there. Second case is for neurosurgery, craniotomy for tumor resection. 45-year-old female, 60 kg, no major comorbidity, scheduled for elective craniotomy for meningioma and ASA grade. Here you see in pre-operative phase what happens. AI system integrates in MRI based surgical time prediction with the patient data. MRI based AI system will integrate this data and they decide that how much surgery time will be there. And when there is a tumor resection, at that time I have to down the light anesthesia to the patients. So it chooses Aliwell model. Third generation Minto model to maintain stable death and anesthesia. The plan includes avoiding deep anesthesia to the enabling SSCP, that is somatosensory evoked potential system, because we are using in neuro anesthesia. Induction target was low dose, means propofol 3.5, which we will not decide, that AI will decide 3.5 microgram and remifentanil 2 nanogram. AI adjusts titration, ensuring smooth loss of consciousness without pneumonia. Now in maintenance phase, when there is a during scalp fixation, null and hemodynamic stress was detected because they raised. AI increased the remifentanil to blunt this response, avoiding hypertension. During tumor resection, AI maintains lighter anesthesia for neuromonitoring accuracy. In intraoperative adaptations, patient develops bradycardia due to surgical manipulation. So AI reduces automatically remifentanil infusion, alerts the anesthesiologist, and surgeon pauses the manipulations. He will stop the surgery, and once the vitals stabilize, then surgery started. In emergence, AI gradually decrease the propofol and fentanyl 20 minutes before. It will decide itself that now I have to stop this infusion slowly, and there is a smooth emergence and neurological wake up. Recovery patient is extubated in OR, minimal hemodynamic fluctuations during surgery, no nausea, vomiting, transport to neuro ICU. So learning point is in neurosurgery, smart TCI TIVA with AI balances depth of anesthesia by unique need of neuromonitoring, ensuring hemodynamic stability and fast safe wake up. Now I will come to my future. This diagram I have prepared in 2018 to have my dream is how this my machine AI enabled anesthesia workstation will be there. I have created only one button. Our all these machines available in the anesthesia workstation available in the markets are having a tremendous this way, all these gadgets. So people are confused. So I have put only one button on that. I have put only one button, awake and asleep. When all the data are fed, then I want to put my patient on a anesthesia mode, then it goes in the asleep mode, and everything will be controlled by this anesthesia workstation and my AI pump. So I called it a switch on switch off anesthesia machine. And when I want my patient should awake, then I have to just switch off this. So this is the way. And I created in 2024 this blueprint, AI enabled anesthesia workstation. So there are some monitors, decision support, voice command, depth of anesthesia monitor, pain and fluid management automated. So I'm sitting here and I want to learn from, this is a robotic arm. Even intubation will be done by the robots, which is incorporated in this. These are the only one vaporizer for all three types of the inhalation agent. There are tanks inside one vaporizer. Even vaporizer will be decided by AI that which agents to be introduced in the body, right, for the gas anesthesia. And ultimately, in 2025 June, I have created this type of the anesthesia workstation, which is very famous now in all over world. This is the 2 robotic arm. This machine is a 2030 my imagination. But believe me, more than 1 crore rupees of trolleys available by Drager in all over world. And we have fortunate in India that 3-4 trolleys are available. In Vadodara, we have 1 trolley is that. And this type of the trolley will be used in 2030. So this for August audience of my PG residents, I want to tell, this is your future. So my key takeaway, smart anesthesia blends TCI TIVA and AI for personalized care. TIVA delivers anesthesia solely via intravenous agents. TCI uses PKPD models to maintain target drug concentration. AI enables real-time adaptations using EEG, BIS, Mentropy and NOL. Closed loop system automate infusion with manual override safety. Benefits include precise depth, fast recovery and less PNV. AI is an assistant, not a replacement. See, there is $1 million questions people are asking, okay, AI will replace everything. Not like that. If you use smartly, then it will never replace your own ability. Challenges include high cost, training needs and regulatory barriers. This will come out in the future when the drugs cost go low, infusion pump cost go low. Future direction are genetics. I will tell you, after 2 years, you will see that in every part of the India and outside world, genome anesthesia will be the hot topics for the discussion. Variables and autonomous systems. My core message of this, my lecture, this is just glimpses of my lecture. Precision with TCI TIVA. You start TCI TIVA, it's a new normal for the anesthesia, coming part of the anesthesia. Adaptability with AI, and those who are, see, there will be 2 types of the world. Those who knows AI and those who do not know AI. So you must know AI in your practice also, and judgment with the anesthesiologist. There are some light humor I have collected. The pump with the attitude. Resident tells that AI, sir, should I set the effect of target concentration manually? AI says, relax, I already know his age, weight, sex, genetics and Netflix history. So lesson is, smart TCI TIVA adapts to multiple patient factor better than guesswork. Coffee versus propofol. Why did the AI TCI pump refuses to give too much propofol? Because it is said this is not a Starbucks, precision dosing only. Smart TIVA prevents oversedation by titrating excitement. Genetics in the OR. Pump says, warning, this patient pharmacogenomics suggests lower metabolism. How do you know that? Unlike you, I read the genes. Smart anesthesia integrates pharmacogenomics for the personalized care. The honest monitor. BIS monitor to the anesthesiologist. Sir, I am at 60. Do not just stare at me. Sometimes what happens in 60 reading of BIS, we think that patient is light. But trust the term. Closed loop systems uses real-time feedback to keep anesthesia depth stable. That is why I told you the incidence that whether patient's BIS level is 60 or 40, this will be decided by the AI monitors only. Lazy anesthesiologist. Colleague says, why are you so calm and during this long surgery? Because my AI TCI pump worries more than I do. Lesson, AI reduces cognitive load, letting anesthesiologists focus on safety. So friends, the good anesthesiologist gives anesthesia, the great one with smart anesthesia care for the patient who receive it, Dr. Tushar Chokshi, myself, and I am a really am telling you, I am a generation of next 5 years, and I am no doubt I am an old man, 60 years male, but